In this lecture, we're going to be talking about the patient, you and the provider, and some legal aspects between the two of you. First, for the provider and patient relationships. When we're called to a scene, whether that's in our facility, 911 response, you're working a standby event, whatever it may be, whenever you're encountering that patient, it's the start of, I think, a sacred relationship. They're turning to you in the worst moment of their life, that whatever has happened, they felt the need that 911, EMS, whomever needed to be called. You're showing up as a medical professional. Because of that and because of the trust that they're putting in you, you should always honor that relationship. And you should always do what's best for them. If you approach every interaction that you're having with that patient as making sure that they're getting your best, that they're getting the highest level and the standard of care that is dictated or needed based on their complaint, you tend to never go wrong. There's really not any possible legal consequence when you can say, and truthfully, not just say it, but know that you acted in the patient's best interest and that you gave them the level of care and you operated within the standard of care that is acceptable and is dictated by what that patient needed. Where people get into trouble or encounter some issues is whenever either they did not do what was best for the patient. They gave substandard care to that patient. They weren't acting in that patient's best interest. Or B, they might have been doing what they thought was best for the patient, but it wasn't within what is realistic and is the standard of care. If you can, and not just keep you out of legal consequences, but back to the whole ethics and moral talk if you've already gone through that lecture. Most people's ethics would push them to treat patients well. EMS is never a profession where you're going to get rich off of it. So most of us are here because we want to help people. This is the time you get to do that, making sure you always do what's best for your patient. Doing what's best for your patient starts with them being an active participant in their care. Consent is key. Consent is always needed. Before we can provide any level of care, we have to have consent. One of the earlier things we should be asking our patient, past just hey, what brought us out here today? Or, what's going on, should be, can I do this? Do you mind if I get your blood pressure? Do you mind if I listen to your lungs? Do you mind if I palpate your abdomen? Giving them the ability to consent to the age or to the care. In order for a patient to provide consent, and there's different types of consent that we'll talk about in just a second, but to provide full informed consent, they have to, one, be of a legal age. There are a couple different ages that'll get tossed at you for different regulations within the state of South Carolina and within other states. But for these purposes and for consent purposes, a legal age is going to be the age of adult, so 18 or older. They also need to be able to demonstrate that they possess the ability to make decisions. And that'll be something we talk about throughout this lecture. But somebody who can possess or possesses the capacity for good decision making or for decision making is somebody who would decide for the care that a reasonable person would want for themselves. If they are of a legal age and they have demonstrated that they possess good decision making or a decision making capacity, whether you think that's a good decision or not, they're always able to refuse care. And with refusing care, it doesn't have to be an all or nothing. If we get there and we ask the patient, do you mind if I palpate your abdomen? And they say, no, I don't like to be touched. That doesn't mean you get to kind of throw your arms up in the air and be like, fine, I guess you don't want me, and you turn around and leave. Think of your care as, not to diminish us to this, but almost like an a la carte experience for the patient. They can consent to certain aspects of your care. So they can consent to transport, but to minimal or no treatment. As an informed patient, they're able to do that. And what exactly is an informed, or what further just going in on that consent? So the different types of consent is, first of all, informed consent. If they are an adult and have demonstrated that they have good decision-making capacity, whether you think that decision is good or not, then they need to have informed consent. This is where you describe what you think is going on with them. You describe the procedure you want to do. Because of X, I'd like to start an IV. Whenever I start an IV, I'm going to clean the skin. I'm going to stick this needle into your arm. Whenever I pull out the needle, it's going to leave a little catheter behind. It's going to allow me to do these things. You're describing what you're asking of the patient, and then they can make an informed decision. Whenever we're administering medications, this will include not only telling them what medicine we'd like to give them, but also what desired effects we're looking for and any adverse reactions they might encounter. That is the informed piece of informed consent. They fully know what they're looking at and what they're going into, and they can make those decisions accordingly. You have a patient with chest pain and you'd like to give them nitroglycerin, and you're describing the nitroglycerin to them. And some of the adverse reactions that most people get from nitroglycerin is a headache. And if you describe that to the patient and they say, no, I don't want to do that, in spite of knowing the benefits of nitroglycerin, they're welcome to do so. They're welcome if they are of a legal age and they've demonstrated decision-making capacity. They can absolutely decline that nitroglycerin, but still get the rest of the treatment and the rest of the care that you're experiencing. They can also change their mind during transport and go back on it. There's then expressed consent. So this is when the patient does tell you, because of the informed consent that you've told them and you've told them everything about the care, they express the permission for you to provide that care to them. You've made them a fully informed consumer of the goods, the care you're willing to give them, and they express their consent. They tell you, yes, you can do that. Yep, I'm okay with that. Implied consent kicks in whenever we have a patient who is still an adult or is not an adult, that they're unconscious, they don't have good decision-making capacity, or whatever their condition is would prohibit them from being able to verbally consent to your care. At this point, it would be implied consent. And what the consent is implying is that they would want whatever a reasonable adult would want done for them. You have a patient who is unresponsive or minimally responsive, and you assess them and you check their BGL because you're a good provider, and you find that they have a reading of low. They're obviously unresponsive, so you're not going to be able to get expressed consent from them to start an IV and to administer a dextrose product. But a reasonable adult, if their sugar were reading low and they were in this state, would be for you to start an IV and for you to give them the dextrose product. So implied consent would allow you to do that. It allows you to treat them in the manner that any adult would want, reasonable treatment would want to be done. Consent really never is involuntary. We don't force things upon people. It's either expressed or implied, and expressed consent should always be informed consent. Whenever we're working with any of these consents, we need to make sure that we're appropriately and carefully documenting what's happening. So if a patient does refuse a procedure or refuse transport, whatever it may be, you need to document what you told them, that you advised them of these risks for refusing that particular treatment or transport, that they then acknowledged it, and your outcome, your treatment after that. So you left the patient on scene, you continued your transport, but withheld this, and that they were advised that they can change their mind at any point. Just because they're saying no now doesn't mean a no forever. If it's implied consent, why did you feel that they fit into that? What state they were unresponsive, so we continued with blah, 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 blah. Speaking of your decision-making capacity, refusals always need to be informed. You can't have somebody refuse that isn't able to make solid decisions for themselves. So they don't have a good decision-making capacity, and they have to be of a legal adult. If they're not a legal adult, or they're not able to make decisions on their own, then they can have a power of attorney or somebody do it on their behalf, and we'll talk about that a little bit more in just a second. But refusals have to always be informed. So in order for them to be able to be informed, they have to meet the definitions or the requirements of informed consent. So they have to be an adult and they have to have good decision-making capacity. And for somebody to demonstrate to us that they have good decision-making capacity, they need to be able to not only understand what we're saying, but be able to process that information and then make a choice on their own. A way that I like to make sure that they're not just parroting back what I've said to them, that they truly have processed and they understand what's being asked or told of them, is they don't want transport. So I would then explain to them, based on the current condition that they're in, what they're complaining of, what some realistic complications of refusing care or transport could be for them. So if it is somebody who takes blood thinners and they had a trip and fall, and they're like, no, I'm not really hurt, I'm okay. Part of their informed consent for their refusal would be making sure they're aware that because of the blood thinner, they could have some type of hemorrhaging inside of their body that I'm not able to see. They could have some type of damage inside of their brain where they have a hemorrhage within there that would be exacerbated by their blood thinners. And what that could lead to you being incapacitated. That could lead to your death. And make it realistic. If somebody doesn't want transport because they stubbed their toe, death maybe isn't a realistic risk for them. But somebody who's on a blood thinner that had a fall, that could be a realistic risk. So tell them realistically what could happen. Then ask them to repeat back those risks of refusing care in their own words. Having them do it in their own words, make sure that they fully understand what you're telling them. That they're not just parroting back whatever you've said, that they comprehend, they were able to process that information and then repeat it back to you in their own words. And then they can make that fully informed choice of what they would like to happen. When you're documenting it, make sure that you documented those are the steps that you've gone through. If you have a patient that you truly feel should not be refusing care, that them refusing care, treatment, transport, whatever it may be, could lead to serious harm for them. And you very much worry about them staying on scene, but they're a competent adult, so they're able to refuse care. You can engage other avenues to advocate for them going. Some of them are less intrusive and some of them get progressively harsher. So first of all, using your people skills, talk to them. Be personable. Let them see and understand that you care about them and you're worried about leaving them on scene. Try engaging friends or family. If there's other people on scene, ask the patients, first of all, for their consent for you to discuss what's going on with that person. Because if you do and they don't want you talking to them, that's a HIPAA violation. So do you mind if I talk to so-and-so about what's going on? If they say yes, then explain to them what's going on, why you're concerned about them refusing care or transport, and see if they can help talk their loved one, their friend, whomever it is, into going and getting evaluated or getting that treatment. If that doesn't work, you can try consulting med control. Whether your medical director is somebody who gave you their phone number that you're able to call them while you're on scene, or you can radio into your closest hospital or the hospital you would be transporting them to. In our society, a lot of patients not idolize, but look up to doctors. Gold standard. They might not fully understand what we do as EMS practitioners, but everybody can understand a doctor and what a doctor does. And sometimes getting that highest level of care to explain and describe to the patient and also express their concern and why they need to come in, they oftentimes will consent at that point and be like, you know what, you're right, I think I will come in. If they have mentioned their primary care physician or some other specialist that they see, ask them if they would be okay with you talking to that doctor. See if you can get a hold of them through their nurses line, their after hours, like whatever it may be. Use those other avenues to engage. The harshest or the highest level would be to engage law enforcement. So they can get a court order and they can do something called EPC, which is emergency protective custody. That patient will be placed into law enforcement custody, not like under arrest, but kind of a similar type thing where they haven't broken any laws, but they're placed in that protective custody because they're not making decisions that a rational adult would. And because of that, law enforcement is going to place them under that emergency protective custody with a court order from a judge. That officer can then make the medical decisions on behalf of the patient, which would inevitably be what we're asking is in their best interest. It can be very difficult to get law enforcement to EPC a patient because it can be difficult to get that court order. They have to prove a bunch of things in order for that to happen. If you are concerned about that patient and you do think that despite them on the outside appearing to have an okay decision-making capacity, but it really would not be good for them to refuse care, engage what you need to. Some factors that can really heavily impact a patient from making a good informed consent or informed refusal would be things like, let's go back just a second, would be things like head injuries, abnormalities in vital signs, like abnormalities in their BGL, in their SpO2, so they're hypoxic or they don't have enough glucose, so their brain's not functioning at its full capacity. Certain mental illnesses can skew it. Any type of cerebral ischemia or stroke that would be altering, again, their mentation. Intoxication, legal or illicit substances. Anything that could be intoxicating could be clouding the patient's mind and the patient's judgment. UTIs, those are known to cause altered mental status. There's this idea that somebody who is suicidal or homicidal is not able to make their own decisions. And I go back and forth with my feelings on this. And kind of the rationale behind it is that somebody who has intentions of harming themselves or harming someone else is not doing what a rational adult would. And so therefore, they don't meet the definition of somebody with good decision-making capacity. And I don't know that I entirely agree with that. I do agree that it's not normal and it's not rational for someone to want to harm themselves, but I don't know that that fully shows that they're not able to make decision capacities because they're not doing what a rational adult would to protect or keep themselves safe. It can be kind of difficult, though, to prove that somebody is suicidal or homicidal and it's not almost like a he said, she said type situation unless the patient is directly saying it to you or like they said it to law enforcement and they have it on body cam. Even when people text things, it can be very difficult in the court of law to prove that somebody else didn't send that on the patient's behalf. So when you are in some of these situations, your best bet is using your people skills. Be personable, show empathy, talk them into it. You can get a pretty far way by exhibiting that you care about them and that because you care about them, you really think the best option is to be transported for further evaluation. So for minors, you have to have legal consent to treat the minors, but they don't meet the definition for somebody who can give you informed consent, right? They don't meet the first one. They're not adults. One, they don't technically have a legal status, so they're bundled under whoever their guardian is. Because of that, the guardian must be the one who refuses or consents to care. You really do need to obtain consent from the parent or legal guardian. And if nobody's there, we're going to make it almost kind of an implied consent. So if the legal guardian isn't there, you can do whatever emergency treatment is needed to sustain the life of that child by implied consent. They just can't make an informed consent because they're not a legal adult. You would have to have their parent, their guardian do it. If the parent or guardian is unavailable, they'll fall into a legal principle called in loco parentis. And what in loco parentis is going to be Latin for in place of the parent. So let's say they're at a school, a daycare, a summer camp, anything like that, where their parent has entrusted them into the care of another adult. The decisions can be made by that adult that they were placed in care of. The school administrators, the daycare director, whoever it may be, they can make the decisions in place of the parent if the parent cannot be contacted. Now, most of those places, as soon as they know that 911 is coming for that patient or for that child, they're already trying to call the parent and figure out what the parent would like to have done. If you can't get in contact with the parent, that doesn't mean you need to cross your arms and stare down the school administrator and be like, well, I guess we'll wait until the parent shows up. No. In loco parentis, the administrator can make the decision on behalf of the child. And that decision should be what a rational parent would want done for their child. Unfortunately, Not all the time do parents and guardians make the best decision for their child, especially when it's like a case of abuse and you're called out and you can tell those signs of abuse on the patient. There can be concern that the parent wouldn't consent to care or good care because they could be caught, right? Because the other signs could be found. So if you find yourself in one of those difficult circumstances where the parent or the legal guardian is refusing to grant consent to treat the minor when they require life-saving or limb-saving treatment, something that would drastically affect the child. Even though adults do have the right to refuse, many state laws, and South Carolina is one of them, where they don't permit a parent or guardian to deny treatment for a child that would constitute saving the child, because in them denying that care, that would constitute neglect, which would mean the state assumes custody of the child. In just a second, we're going to talk about mandatory reporting, but this would fall kind of in that classification, that if for any reason the parent is not making the best decision on the child's behalf, then the parent is no longer the one making the decision. The state is. You would need to contact law enforcement, and this would be working in conjunction with them. So law enforcement would be contacted, child services would be contacted. They would take custody of the child, and they would make the decisions on behalf of the child, which is going to be to do whatever is needed to save or stabilize that child. If a patient is emancipated, this can be where it gets difficult. So emancipated minors are under the legal age, but they're given the same rights and responsibilities as a legal adult. There are different circumstances that would allow them to qualify for this, and every state's going to be slightly different. In most every state, though, for a minor to be emancipated, they have to have a court order. That court order has to have the reason that they were able to qualify for emancipation. They got married. Marriage laws in varying states are kind of odd. They're pregnant. They're in active military service. They were able to prove that their parent was treating them neglectfully, and they were old enough that they were able to prove that they could then also take care of themselves. If they're emancipated, they'll have the paperwork to show you. Here's where it gets kind of weird in the state of South Carolina. So a minor is able to make their own medical care or medical decisions while they're actively pregnant. Once they've delivered that child, they can make the decisions for the child, but if they are still under the legal age and not emancipated, so they don't have that court order, then their parents still make their decision. So let's say you have a 14-year-old girl who gave birth, so she has a baby, and they're both involved in a car wreck. That child, that 14-year-old girl, can make decisions for her child and whether she can consent and refuse treatment. She cannot make the decision for herself. Her parents have to make that decision unless she can prove that she has that court order that officially emancipated her. If they're telling you that they are emancipated but they don't have the documentation to prove so, be prepared for transport. It's kind of similar to like the DNR, where they have to be able to prove that they are emancipated on the legal side, and you can get law enforcement involved if needed. So for mandatory reporting, every state has their own requirements. For South Carolina, you are in the grouping of mandatory or a mandated reporter. What this is going to mean is that people who are in at-risk populations, children, elderly, people with special needs. So people who we know are at risk and who are at high likelihood of being preyed upon. When you notice anomalies or abnormalities with them, think abuse. You are required to report it. Required. You notice signs of bruising at various stages. You notice that that child has, or elderly adult, has a very strong smell of urine, and you look under their diaper and you notice like burns from the urine and they haven't been changed in so long. They have pressure wounds that aren't being addressed, and the family doesn't seem to, or whoever's caring for them doesn't seem to notice or care. They have an injury and the story you're being told doesn't really match the injury pattern that you're seeing. And you have those other signs where the child seems or adult seems slightly scared of the other adult. The other adult is answering on behalf of them if that person would normally be able to speak for themselves. When you separate them, you start getting differings of stories. All of these are signs of abuse. You are required to report it. Failure to report it would be a crime and you could face criminal charges for it. This also includes sexual abuse and drug-related issues when, again, they're very old, very young, would not at risk, special needs. And it looks like they've been given those drugs by somebody else. You have only satisfied your obligation in this state as a mandated reporter when you make the report. You contact law enforcement, you contact Child Protective Services, you contact Adult Protective Services. You letting the hospital know upon turnover does not satisfy your requirement of mandated reporting. The hospital has to report it as well. But you simply telling the nurse the things that you saw and why you're expecting abuse does not constitute you reporting it. You have to report it to the appropriate authorities. And your services should all have some type of procedure policy in place of exactly how they want you handling it, who they want you calling, how they want you going about it. But it has to be you making that contact. And honestly, having been on the side of making the report and seeing how slow some of these processes happen because they're all perpetually overworked. Unfortunately, abuse is very common. And so these agencies, on top of abuse being very common, are chronically understaffed. And so for things to happen and happen quickly, normally they need an abundance of phone calls. So you calling and then the hospital calling and then the doctor calling, because everybody's got to report it, is important. Now, all that to say that just because you telling the nurse doesn't satisfy your requirement as a mandated reporter does not mean that you don't have to tell the nurse. So you do still have to tell the nurse or the doctor, whoever, during turnover. If you have a suspected abuse situation, without creating a violent interaction for yourself, try as best you can to separate the abuser from the abusee. Try your best to make sure that you get your patient into a safe environment, again, without setting yourself and them up for a very awkward and possibly violent situation. Awkward's fine. Violent would be the issue. Don't look them in the eye and be like, I know what you've done. You can't ride with me. Why don't you meet us there in your car so that way you have a means home afterwards? Our policy, a lot of places, policies don't allow patients, families to ride in the ambulance anymore post-COVID. You can say that. Hey, I need you to grab this before you can come to the hospital and meet us there. Something to try to get that patient into a safer situation where they may be able to talk to you a little bit more. We unfortunately encounter this far too often, and that's patients who are violent to the point that we need to restrain them. And there's two different levels of restraint. So there's physical restraint, we actually tie you down, and then there's chemical restraint. We give you some type of medication, normally either a benzodiazepine or ketamine, so that we can sedate you enough that it's safe enough for us to get you to the hospital. And when we're looking at that violent patient and whether or not we need to restrain them, we need to make sure that they're a threat to us or to them to the point that we're not able to verbally de-escalate them. And verbal de-escalation will be a talk in another chapter, so we'll save it for that. But you can only use force against somebody who is a threat to you. So if they're using force against you. So if they're just screaming at you and calling you profanities, but they're not being physically violent towards you, I'm so sorry, that's not a reason to restrain somebody. If they are acting or being physically violent towards you, you can. You need to make sure that you have law enforcement there. You need to make sure that you have plenty of hands so that you can safely restrain the patient. This picture is actually not a bad one of how we can safely restrain somebody. So they have somebody holding down his legs, they're holding his arms, and it looks like they already have his hands kind of tied with cravats. You then see that the rest of the restraints they have on are just the standard seatbelts. We never want to restrain somebody across their chest, across their neck. We don't want to do anything that's going to restrict their ability to breathe. Because of this, restrained patients should also not only be some position other than prone, but they really shouldn't be supine either. We should have them in some type of semi-Fowler's position so that they're able to maintain their own airway adequately. If you do have that patient who's violent, think about why they may be violent and if it's something that you can fix. So is it something like hypoxia, hypoglycemia? They have some type of brain injury. They're on some type of illicit substance or just alcohol. It is mental illness that's causing it. So they have some type of psychiatric underlying cause. And if there's something that you can fix and you can address with it. If it's hypoglycemia, treat their sugar. Don't sedate them. Give them the sugar they need. If they're hypoxic, start administering oxygen. And honestly, good practice, any patients who's being restrained, whether it's physically or chemically, needs to be on oxygen. Because that is where we run into trouble. As we restrain somebody, we don't ensure that they're properly ventilating and properly oxygenating themselves. And then they end up either deteriorating or going into cardiac arrest. We need to make sure that if we are going the steps, that we are taking somebody's ability to protect themselves away. We're restraining them physically or chemically. We have assumed full responsibility for that patient's well-being at that point. I've taken away their mechanisms to protect themselves. I need to make sure that I am protecting them on their behalf. Quick talk about some negligence. This was already hit in a previous lecture, but we're just going to review it again real quick. So negligence is whenever you fail to treat the patient as you should. You have a legal duty to provide a standard of care to a patient. Whenever you don't do that, you give them substandard care, whether it is with or without malice. So whether you intentionally did it or unintentionally did it, you have committed negligence. You've breached your duty to that patient. You caused additional injury, additional harm, because you did not give them the standard and the amount of care that you should. While your employer does maintain insurance to help with negligence and malpractice, you as a provider really should get malpractice insurance. It's not very expensive. It just protects you because even in those instances where you weren't doing it with malice, sometimes things unfortunately happen. If you don't have malpractice insurance and it was where even if it wasn't intentional, you violated one of your guidelines, you did not do something appropriately per your agency's policy, their insurance is going to protect them, but not you. So having that malpractice insurance just ensures that you still also have that protection. The last thing I want to talk about is the legal aspects that apply to provider and patient interactions is abandonment. And this is whenever we stop caring for the patient without their consent. They didn't refuse to the care. We just kind of leave them. So we initiate, we start assessing or have made contact with that patient, and then we leave. Once you have responded to the call, once you have established patient contact, you cannot leave without either that patient coming with you or the patient's consent and you leaving them on scene. This can get tricky, especially if the scene starts to devolve and starts to become somewhere that is unsafe for you to be. If that does happen, and it is now a change in scene, it's now unsafe, you need to get law enforcement on scene and contacting with your supervisor and following your other policies about how exactly do you handle that particular situation. But outside of the scene turning violent to where it's now unsafe for you and your partner, you cannot terminate care without consent or without meeting other guidance. It was a cardiac arrest and you worked it to the point that you were able to terminate on scene, or you got medical control to allow you to terminate on scene. But even then, you've rendered the amount of treatment that was necessary. It's not abandonment. You've fulfilled your duties. That is going to be the end of our patient-provider legal aspects. If you have any questions, please let your instructor know.